This is the Blood Bank Guy Essentials Podcast, episode 022.
So our question for Inform was, do hospitalized patients who require red cell transfusion have a lower frequency of in-hospital mortality if they're transfused with the freshest available blood versus the oldest available blood? So this is actually a very different type of question.
Hi, everyone. Welcome to the Blood Bank Guy Essentials Podcast. This is Joe Chaffin, and I'm honored to be your host. Today, I'm going to be speaking with Nancy Heddle, who is the lead author on the Inform trial. This trial was recently published in the New England Journal of Medicine, and it was designed to start, at least, to put an end to the question that we've been wondering for a while, which is, does bad stuff happen when you transfuse people, quote unquote, old blood? The Inform trial is a huge study, and Nancy has a whole lot of details and is going to be sharing some really, really interesting information. So I don't want to make you wait 1 second more. Without further comment, here is my interview with Nancy Heddle. All right, everyone. As promised, I am thrilled. I mean, beyond thrilled. I'm super, super excited to welcome to the podcast today Nancy Heddle from McMaster University in Hamilton, Ontario. Nancy, welcome to the Blood Bank Guy Essentials Podcast.
Thank you so much, Joe. I'm just as excited to be here.
You know, I'm not sure that there shouldn't be anyone in blood banking and transfusion that is unfamiliar with your work, but just in case anyone is, living in a cave for the last 20 some years or so, I would like to tell everyone a little bit about you with your permission. You okay with that?
No, I'm okay with that.
All right. I'll try not to brag on you too much, but there's a lot of good stuff to say, really. Everyone, Professor Nancy Heddle has an incredibly distinguished career in blood banking and transfusion medicine. She's actually trained as a medical laboratory technologist. She has a master's from McMaster University in Hamilton, Ontario, and she is currently a professor emeritus in the Department of Medicine at McMaster. She's also the research director at the McMaster Center for Transfusion Research. She's been an educator, a mentor. She's taught transfusion science and research methodology to over 170 fellows, residents, graduate students, and medical laboratory technologists. She's published over, stick with me here, 170 scientific papers and given more than 220 presentations around the world. In fact, I think I first became aware of Nancy way back in 1994 when she published one of the groundbreaking papers in transfusion medicine in the New England Journal, where she was as far as I know, and correct me if I'm wrong here, Nancy, but the first one to really postulate or really show that febrile non-hemolytic transfusion reactions in platelets could occur as a result of stuff that accumulated in the plasma. Am I describing that appropriately, Nancy?
You're describing it very scientifically, yes.
Yeah, the stuff in the plasma. Yeah, that's. I always try to stay really on the high end of the science talk here on the Blood Bank Guy Essentials podcast. So.
Excellent. Well, it's interesting because that particular study was done, and we found a significant result with 12 patients. And the study that I'll talk about today had 31,000. So two contrasts at the beginning and the end of my career.
Well, I hope it's not the end. Let's just the continuation of your career. Further, Nancy she's been an associate editor for the journal Transfusion since 2004. Her national and international awards are again too long to mention, but I do want to mention a couple of them because they're really cool. First, in 2009, the International Society of Blood Transfusion awarded her the International Woman in Transfusion Award. That's a cool award right there. And then the most recent one, which is really excellent. Just recently at the American Association of Blood Banks, the AABB annual meeting in Orlando in 2016, she was awarded the Emily Cooley Memorial Award, I believe it is, for her numerous contributions to clinical research and her ability to combine her expertise in blood banking, clinical epidemiology, and biostatistics. Nancy, wow. So
Well,
when I read all this and I hear all this, I really, I just have to give you a little career advice. I think you need to get going a little bit because you seem to be slacking to me.
okay, I'll see what I can do.
Okay.
Thank you for the kind introduction.
Oh, you're very welcome. Well deserved. What I wanted to talk about just a little bit before we get going on our topic is, first, what got you interested in transfusion medicine? What was it about it that kind of pushed you in that direction, made you say, "Wow, this is really it for me"? And further, for those, I really want to make sure that those who are laboratory scientists understand that someone like you that has an amazing international reputation. I want to make sure that laboratory scientists don't limit themselves in terms of their thinking, in terms of what they can, the possibilities for their future. So I would like for you to also, as you talk about that, just how did you integrate your background and your training with getting beyond any artificial limitations of, this person is not a quote unquote doctor, whatever. Can you talk about all that for me a little bit?
Sure, I'll take a few minutes and talk about it. It's actually an interesting question how I got involved in transfusion medicine, because I came so close to working in the clinical chemistry laboratory that you would not even believe it. I loved clinical chemistry when training, probably way before your time, Joe, but this was in the era of auto analyzers, which
Okay.
was the method of automation in chemistry. And I used to even come in on weekends and fix them and just help the staff. And when I look back at that, I think to myself, I must not have had a life back then. But anyway, it was very close going into clinical chemistry. But the last 2 weeks of my training, I got sent back to transfusion medicine. And it was just different from the previous 6 weeks of training, clinical training that I had there. There was a new manager who was very inspiring, and I think that's a key point of getting interested in anything. They gave me interesting things to do as opposed to the typical student things that you're supposed to do on the bench to learn techniques. And I had actually accepted a job in clinical chemistry, and I went to the lab director because I knew that there was a job in transfusion, and I said, can I have that job instead? So I ended up in transfusion, and that was great, and I really enjoyed it. But probably when I was in my early 40s, I think that's when all of us start to have a midlife crisis. And I just felt that I needed something else. And in fact, I even applied for a pharmaceutical job, which I'm so glad they did not hire me.
And all of us should be glad that they didn't hire you.
So, but what I ended up doing, because again, of various mentors at McMaster, was doing a master's degree in health research methodology, which was a program that taught people how to do clinical research and how to do it well. And that allowed me to combine those new skills with the expertise that I had already gathered in transfusion medicine for working there for 15, 20 years. So I actually found it very easy to transition into clinical research. You just have to have a good relationship with physicians and, be willing to collaborate and be involved in people and with people. And before I knew it, I was answering questions and publishing, as you said, one of my first studies in the New England Journal, which kind of set my career off in terms of lecturing all over the world.
Sure.
So,
Start low. Start with kind of a low profile journal like that.
yeah. Well, it took me almost another 20 years to get my second paper in the New England Journal, so it's not easy. But, I guess I would say to people who start off as medical technologists, there are a lot of different career options. And the clinical research path is one that I don't see very many technologists taking. But I think it's an area that if it's of interest and you kind of excel in that area, it's another career opportunity that people should think about.
Yeah. Well, you have certainly blazed a trail for that, and that thank goodness the pharmaceutical industry wasn't ready for you. Because we certainly are, Nancy, and you've made enormous contributions. And in fact, with that transition, I want to take us to our topic for today, which is another article that you have recently published, which is equally groundbreaking. It's not quite as new a topic, I don't think. In fact, I know as the platelet study from all those years ago. But it's a hugely important topic, and it's something we've been dealing with for a few years. But so everyone, we're going to talk today about the potential complications and the effect of short-term versus long-term blood storage on mortality after transfusion specifically. That's the article that Nancy and her colleagues published in the New England Journal of Medicine just very recently. Beg your pardon. I believe it was late October, Nancy, is that correct, when it was published?
Yes, it actually came out. I presented it at the plenary session on Monday, the 24th of October at ABB, and the New England Journal very kindly coordinated the online version to come out that morning.
Excellent. Okay. Well, so the study it goes by the shorthand INFORM, INFORM. But before we get to the specifics of the study, Nancy, I think it's important that we lay a little bit of groundwork. So, we certainly know it's not. I'm not telling anyone listening to this podcast anything they haven't heard already. That blood can only be stored for certain defined periods of time. So I guess my first question to you is: can you give us just a little bit of background on who decides that? How is it decided how long blood can be stored? For example, with red blood cells, typically in additive solutions, stored 42 days. Who makes up those rules?
They are a regulatory requirement for companies who are working on developing and trying to license a new additive storage solution. So, the FDA in the U.S., Health Canada in Canada, and there's other agencies in Europe. And what the regulators require is they need some data in two areas. One of the areas is viability of the cells, and the second area is the physical integrity. So the way that they require viability to be demonstrated is by taking a sample of the blood once it has been stored for whatever time period the company is trying to get it licensed for. So let's just say 42 days. And they radio label that sample with chromium-51, and they re-inject it back into the original donor who donated that unit of blood that has been stored. They then take samples at regular intervals, and they actually measure the chromium label and do a fancy calculation, which will calculate the recovery of the red cells. And the regulators require that 24 hours after the reinfusion of these chromium-labeled cells, at least 75% of the cells have to be recovered. And if it meets that criteria, then that's the first one for actually licensing a new product. The second requirement is actually physical integrity of the cells, and the way they require companies to determine that is just by assessing hemolysis at the end of the storage duration. So they just measure free hemoglobin spectrophotometrically, and the standards there in the U.S., there has to be less than 1% hemolysis. In Europe, it's actually a little more stringent. It's less than 0.8% hemolysis. But in most cases, the storage solutions we're using nowadays, they're probably half of those values. So they show really, decent values in terms of recovery and also minimal hemolysis. It's interesting, though, that this is all done in volunteers. So it's normal, healthy people who donate this blood, so the blood donors. And I guess one of the things that we don't know is what actually happens when it's transfused to patients. Are they the same as normal, healthy people and blood donors.
Yeah. Okay. So I think that helps us get a little bit of background on how it's decided. But I think that most everyone is aware also, though, that even though we can store the red cells for that long, they don't necessarily look as great or maybe even act as great as they did when they were first collected. So can you talk to us a little bit about what some people have called the storage lesion of blood, or what happens in the bag during that shelf life?
Yeah, there's a lot of interesting things that happen in the bag, and you've obviously been looking under the microscope and at these cells, which do not look normal at all. So there's a lot of structural changes that go on as blood is stored. The cells have a more crenated appearance. They can actually clump and adhere together. They're not nearly as deformable as they are when they're fresh, and they adhere to endothelium. So it's known that the structural changes do occur. There's also biochemical.
Nancy,
yeah.
I'm sorry to interrupt you, but before you move on from structural, can you explain to us why it's important, why deformability is important?
So deformability is important because in order for red cells to make it through the microcirculation, they have to be able to change shape. And that's why, of course, red cells are biconcave discs. If they were spherocytes, when they got to these small vessels, they would just occlude the vessel and get stuck. So it's important that they be able to maintain that discoid shape, that they can pass through the microcirculation to deliver oxygen to the tissue.
Got it.
So the second category that I would probably lump changes into are biochemical changes. Probably everybody's familiar that 2,3-DPG diphosphoglycerate is required in order for red cells that are carrying oxygen to be able to release that oxygen to the tissues. And what happens during the first couple of weeks of storage is you get decreased levels of 2,3-DPG. When you transfuse that blood, those levels will regenerate. But, there's a period of time there where you're giving blood, especially in a situation where the patient really needs to have oxygen transport, and the cells may not do as good a job as what they will a few days later. You also get decreased ATP because glycolysis is going on, and so the cells just are decreasing their ATP, and you also get a decrease in nitric oxide. And there's been a lot of focus recently on nitric oxide because it's a vasodilator. Which means that, it will dilate the vessels and allow blood to get to the organs and tissue where, again, oxygen is needed. And so with decreases in nitric oxide, again, that process is impaired. And finally, probably the vaguer area of changes is immunological changes. And we don't really know an awful lot about this, but we do know that when cells are stored, they release all sorts of bioactive substances. They release microparticles, and these may come from red cells or platelets or white cells if, in fact, the blood is not leukoreduced. You get little bits of what's called cell-free DNA, so little snippets of DNA floating around. There's bioactive lipids, and those compounds, in fact, have been implicated in Trally types of reactions. And in general, there's a lot of evidence, both from lab studies, animal studies, and a few human studies that suggest that some of these compounds that are produced may contribute to things like infection, inflammation, increased or hypercoagulability, which could lead to thrombotic complications in patients, or endothelial injury. So a lot of different things are happening in that bag of blood that it's stored. And I think what we don't really understand is the impact of all of these changes on patients when they're transfused.
Right. And that is really that's the big question, isn't it? I mean, that I recall, I don't know. I don't know when to exactly pinpoint the date or the year, if there's even possible to pinpoint the year that the so-called patient blood management movement really got going. But I certainly have sat in many lectures, including lectures given to clinicians, where people show these horrible-looking pictures of the structural changes you were talking about with the red cells, and they terrify the doctors with 2,3-DPG and nitric oxide stories, and the obvious implication, I mean, if I were a clinician sitting there, I'd go, oh my goodness, why should we ever transfuse blood? It looks awful.
Yeah.
But I think one of the things that has come from that kind of, maybe inadvertently, and I'm not sure if there's a direct connection, but the timing seems a little suspicious, is that we've had that very question that you were asking. What does that mean? What does that mean about older blood? And there some studies popped out, some discussion popped out about that, that ultimately led to you doing this study that you guys have done. But can you talk a little bit about what started to come out as maybe as a result of those discussions on how blood ages and the storage lesion? What kind of background things led you to consider doing your study?
Yes. So I think if I were to pinpoint, for example, when the blood management movement started, it probably started after the TRIC trial was published. And I think that was I can't remember if it
was 99.
99.
It was.
And, in that trial, they showed that, in fact, patients who were exposed to more blood, so using a higher trigger for transfusion, those patients actually had decreased survival and other morbidities that happened. And so the storage lesion was certainly well known, or starting to be clarified in terms of all the different changes throughout the 1990s. But then when the TRIC trial came out, I think people started asking the question, okay, so could the storage lesion be responsible for what we're seeing, that patients who are transfused at a higher trigger, in fact, their morbidity and mortality would be higher? And it was interesting what happened then throughout, the decade of the 2000s, because you had a lot of people trying to answer this question. And I think in total, there was over 30 retrospective observational studies that were done to try and answer this question. And most of these studies, in fact, showed that or concluded that older blood caused more harm, whether they were looking at morbidity or mortality. There was also a few small randomized trials that were published in the late 90s, early 2000s. But these studies, it was really small sample sizes. Most of them had less than 100 patients. And it was interesting because the results from these small trials, as you might imagine, because they were underpowered, that they were not statistically significant, but the trend was in the opposite direction from the observational studies. So it really led people to say the only way we're going to answer this question is if we do a large enough, adequately powered trial. And so there's been, over the last 10 years, probably about 6 different fairly large studies that were designed and funded and implemented to answer this question. One of the, a couple of the well-known ones would be the RECESS study that was done in the U.S., and in fact, they showed no difference. And then the ABLE study, which was even about twice as large as the RECESS study, and it was a study done in patients in the critical care unit. And again, it showed that, in fact, older blood was I guess we should phrase it that fresh blood was not better than older blood.
Right.
It wasn't statistically significant. But the trend there, again, was a slightly higher frequency of mortality, in fact, in patients who got fresh blood. Mm-hmm. So, I'll just also say that this is a really difficult question to answer, because if you think in our hospital, 10% of patients who get transfused are going to end up dying. And, that doesn't mean that they die because of the transfusion. These patients, because they're being transfused, they're sick. They've got a lot of comorbidities. So the real question, looking at the age of blood, is like trying to find a needle in a haystack, because it's not that blood is responsible for that 10% mortality. Blood may have some characteristics during storage that make it responsible for maybe 1% of that 10% or 0.5% of that 10%. So when you think about it that way, it's very obvious that you'll only answer this question if you've got a very large study with a lot of people to try and detect those small differences.
That's absolutely true, and that's and that will bring us in just a second to how you guys designed and outlined your study. But before we do that, I realize as I'm listening to you talk that while the majority of people listening to the podcast are going to know this very easily, so I don't want to spend a lot of time on it. Those that are, for example, first year residents or students who haven't done a whole lot of work in transfusion services, can you illustrate just really quickly how we normally handle what blood we give out in a transfusion service? Because what you're describing, if all of a sudden blood banks have to start choosing, if that observational data had been proven true, if blood banks had to start switching around how we're doing stuff and giving people the freshest possible products, how would that impact a hospital transfusion service? How would it change what they would normally have to do?
I think certainly in Canada, I can tell you that the practice is to always give out the oldest units of blood first, unless there's some so-called indication for fresh blood. If a study like the ABLE study or the RECESS study, which evaluated whether fresh blood, which was defined as, let's say approximately 8 days or less of storage, whether that blood in fact improved outcomes in patients. If the studies had shown that that was the case, then I guess that would mean that blood suppliers had to supply all of us with blood that we're only going to keep for 8 days. And I think that is just not going to be feasible at all. There's just no way they could keep up with that. So, I think the blood suppliers, with the results of the INFORM study and some of the other studies, which we'll talk about in a minute, I think blood suppliers have kind of, had a sigh of relief that they don't have to decrease the storage age.
As someone who currently works as medical director for a blood supplier, I can tell you that I'm wiping the sweat off my brow. That's for sure.
Excellent.
Definitely. Well, so we've teased this enough, Nancy. We need to get to this and let's hit it. So the INFORM trial that you and your colleagues designed. First, if you wouldn't mind, tell us what it stands for, because it's an acronym, and then further, just take us through a little bit about how you set up this study.
Okay. So INFORM stands for Informing Fresh versus Old Red Cell Management. And I don't know, like everybody wants to have an acronym for their study, and we came up with INFORM, and I'm not even sure how we came up with it, but I kind of like it.
It's clever. I like it too.
And so, we spent about 2 years doing some preliminary work to come up with the right design for this study. And what we were hoping to do with the INFORM study was to actually get at that issue that, the patients who are transfused are going to be most likely the patients who die, but transfusion doesn't account for all of that death. And really, to get at the question, does it account for any of it? So what that really means is we were trying to detect a very small difference, a difference in mortality, an absolute difference in mortality between treatment arms of about 1 to 1.5%. So the research question, and anybody who knows me knows that I have to have a well-defined research question. So our question for INFORM was, do hospitalized patients who require red cell transfusion have a lower frequency of in-hospital mortality if they're transfused with the freshest available blood versus the oldest available blood? So this is actually a very different type of question than what all of the other studies that were ongoing at the time, that we started the INFORM study. All of these other studies were what we call efficacy studies. So they picked very high-risk populations. They defined fresh blood as being very, very fresh. And so what an efficacy study tries to do is to make sure that if there is a signal, you're going to pick a population and choose conditions or set conditions throughout the study that is going to be most likely to detect that difference if it exists. The INFORM trial was a pragmatic trial. So that's really a real life study. So how would this strategy of giving fresher versus older blood work in real life for patients who are being transfused? And so, one of the things you'll notice from the research question is we also included all patients in the hospital, with a few minor exceptions, who were receiving a red cell transfusion. The other studies had just looked at basically the cardiac surgery, the critical care patients, those high-risk groups. And it begs the question, well, what about my patient who's on the general medical ward? Or what about my patient who's undergoing another surgery? So we wanted to be able to hopefully come up with some conclusions that applied to a very broad range of patients. And in methodology terms, we call that generalizability of the study. So that's why, so there were a couple of reasons why we did INFORM. First of all, we wanted to try and detect that smaller difference in of morbidity or mortality in our case, if it did exist. We wanted to make sure that we had this broad patient population, so we had generalizability. And those were really the two main issues why we felt that a design like INFORM would be very complementary to the design of the ABLE study and the RECESS, which were designed as efficacy studies. So that was the rationale for doing it. So I guess I'll stop there for a second. Do you have any questions about that, Joe, or do you want me to go on and explain the design?
Maybe we'll talk again towards the end on what you see of the future of the quote unquote pragmatic study, because I think that has there's some really cool possibilities based on what you're describing, and I love the idea of. I'm about as real world a person as you'll find, and I love the idea of stuff being able to really apply broadly rather than in specific categories. But let's go on and talk a little bit about how you set this up.
Okay, so as I said, the eligible patients in this study were anybody who was admitted to the hospital and they requested a red cell transfusion. And I really have to acknowledge the transfusion services here because they're the ones that ran this study. They had a randomization scheme which was They didn't know which treatment was coming up next. They just logged into a computer. At the time that a red cell transfusion was going to be issued, or blood was going to be issued for the patient, and they randomized the patients to either the freshest blood in the bank or the oldest blood. And that was another feature that made this pragmatic, because, we didn't define a threshold for fresh, which is, again, more real life. If fresh had turned out better, I think you would have been more interested in knowing, well, can I give up to, 14-day, 21-day, how do we define fresh? So this study helps would inform that question too. So the blood bank staff, kudos to them. They did an exceptional job. We've randomized patients in an unbalanced randomization. So for every one patient who got randomized to the fresh arm, we assigned 2 patients to the older blood arm. And remember, I said a few minutes ago that we spent about 2 years doing various pilot work to figure out how to design this. The reason that we did that, there was actually 2 reasons. First of all, by doing that, we showed that we could get at least a 10-day difference in the mean age of blood that was transfused within the 2 groups. So we could get a decent spread between the 2 groups in the age of the blood. And the second reason we did that is if we had done a 1-to-1 randomization, I think we would have outdated blood because we're using up fresher blood, and some of the older blood isn't being used as frequently, and it would have gotten to 20 or to 42 days and we would have had to discard it. And blood donation is a valuable resource, and we didn't want to waste blood. So that's why we used the unbalanced randomization. And we simply said, okay, if the person is randomized to fresh, give out the freshest unit of blood that's ABO compatible that you have in the bank. And if they're randomized to the oldest, to give out the oldest, which was standard practice in our centers. The outcome that we looked for was in-hospital mortality. And, although you don't like to think about patients dying, it's a very objective outcome. There's no way that it can be miscategorized. So from that point of view, the fact that the study was not blinded, if patients wanted and physicians wanted to look at the unit of blood that was hanging to figure out whether the patient was getting fresh or old, they could have done that. But the fact that the outcome was a very objective outcome, removed any concerns about the fact that it wasn't blinded. So we ended up with 3 sites in Australia. 3 sites in Canada, 1 site in Australia, 1 site in Israel, and 1 site in the U.S. that participated in the study. And I think for me, one of the coolest things about the study, and anybody who's done any type of project will appreciate this, is we didn't have a single data collection form. Nobody had to collect a single piece of data. We pulled all of the information directly from the laboratory computer system and from the electronic chart medical record system. And that's, again, another pragmatic nature of the study, that we were able to enroll a huge number of patients because we didn't have to have somebody running around collecting information on every transfusion and how the patient was doing. Another interesting part of the study is the research ethics boards at all of the participating sites approved the study without consent. So we had what's called waived consent. And the reason that they did that is because nobody got a unit of blood, whether in the fresh arm or the older arm, that was outside of the standard of care. So nobody got blood greater than 42 days. And that allowed us to have this waived consent process. Without, the electronic data collection, the waived consent, it would have literally been impossible to enroll over 31,000 patients in the study.
Wow. That's a big number. Over 31,000 patients that you randomized.
Over 31,000 patients were randomized. In the primary analysis, a little over 20,000 of those patients got into the primary analysis. The primary analysis included only group A and O patient, not Bs and ABs. And again, this was preliminary work that we did where we showed that because, for example, AB blood, most of the blood banks only had 2 or 4 units in stock. It was impossible to get an age spread between fresh and older blood.
That makes sense.
So it didn't work at all for ABs. B people, we actually, when we analyzed the data, we got a much better age spread than what we modeled in the pilot studies up front. But we had specified that only A's and O's would be included in the primary analysis. We did a secondary analysis where we did throw in and analyzed also the B and AB patients. And again, the results were pretty similar. So not everybody who was randomized was actually included in the analysis, because the other thing, and we knew this was going to happen, some patients got randomized in eMERGE because they were looking for a bed and they wanted to get them into the hospital. And I don't know, maybe this is the Canadian system, but sometimes they would sit in eMERGE for 7 days because there was no bed available.
Oh, wow.
And then ended up being discharged. So some patients didn't get admitted, so they couldn't have in-hospital mortality. And some patients, in fact, didn't get transfused. And the primary reason for that was patients where blood was being sent to the OR in coolers. We randomized the patient, and then the patient didn't end up using blood.
Oh, I see. Okay.
Yeah.
I think that's what you just said is a little bit eye-opening to me, because I actually had not thought about the fact that you were including transfusions like that, where you put something in a cooler and send it to the OR. You guys really were going for a very broad swath of patients, weren't you?
We were. A lot of the laboratories have that practice of sending blood in a cooler or to an external fridge near the OR. And we would have missed all those surgical patients had we not done that.
And one other point, and I believe this is correct. Please correct me if I'm wrong, Nancy, but I believe you did not include the pediatric population in this group.
No, that's correct. So for example, in Hamilton, we have 4 hospitals. One's a children's hospital, and we didn't include the pediatric group. When there is another study that's going on right now, it's called the ABC PICU study. I think it's scheduled to complete enrollment and be finished sometime in 2018. And it's looking at pediatric ICU patients. So I think it will be important to see that population. Will they be any different than what we're seeing in the adults? I suspect not, but at least we'll have those results when that study is finished.
Got it. Okay. Well, Nancy, you've kept us in suspense long enough. We've drawn this out as long as we can. Now, obviously, it's really important for people to understand when you hear the conclusions, everyone, it's important for you to understand how this was put together and who was being looked at. But Nancy, no more waiting. What did you guys find?
Like, are you going to give me a drum roll or anything?
I should.
Yes.
If I could do that. Let's see. Hang on.
No.
It's not very good, but go ahead.
Okay, so let me just give you, first of all, some general descriptive characteristics. So As I said, there was a little over 20,000 patients who were Group A and O that made it into the analysis. When you look at the proportion of males to females between the fresh and the old group, the age of the patients, their blood group, and also their diagnosis, they were very similar between the two groups, which you would expect because that's what randomization does. That's why randomization is so powerful compared to just observational studies. We were able to achieve our minimum of 10 days storage between the two treatment arms. So the median storage age in the fresh group was 11 days, and in the older group was 23 days. So we actually exceeded that. So we had pretty good separation. When we did the analysis, we looked at all patients, and in fact, we found that there was no significant difference between the patients who got fresh blood and those who got older blood. And I'll just emphasize here that our hypothesis for this study was that fresh blood would have lower mortality. And the results just showed that we were not able to show that there was significantly lower mortality in that group, keeping in mind that we had good power to be able to detect about a 1.2% absolute difference. So if there is a difference, it had to be less than 1.2%. We also looked at 3 different subgroups of high-risk patients. So we looked at the cardiovascular surgery patients, patients in the ICU, and patients with cancer. And in fact, the cancer patients are a group that had not been studied by anyone else. And in all those groups, again, we showed no evidence that fresh blood was better than older blood. And we also did analysis which are called looking for heterogeneity between, for example, centers. We looked at country, blood group, and also diagnosis. And there was no evidence that between the different centers that results were any different when we did that. So like other studies, like the ABLE study and the RECESS study, the INFORM study showed that there was really no indication to give fresh blood because there's no evidence that fresh blood decreased mortality in our patient population or in the other studies, which not only looked at mortality but also various morbidities. So that's what we found.
If I could put in like an applause thing, I would do that. In fact, I might do that in post-production, Nancy. We might.
Okay.
When you hear this podcast, there may be an applause going on in the background. I could.
You're so technically savvy. What can I say?
So, I mean, I think that's it's obviously an incredibly important finding, and with everything that you've said, it's really great news for us in the blood bank. There's a couple things I wanted to ask you about really quickly. First is your difference in median storage between your so-called fresh blood and so-called old blood, and one thing that I have heard a couple people mentioning is that, boy, I wish that median storage number, the 23 days for the quote unquote old blood, would have been a little bigger or would have been a little higher. Do you have any comment on that and what that means? Yeah,
so that's the big question that, a number of people, there have been some editorials and articles written saying that, for these studies, the results really do not address the question of whether there's a difference in terms of patient outcomes between really, really fresh blood, let's say under 8 days, and old blood, that last week of storage. And so when we designed INFORM, because we didn't specify a cut point for fresh blood, we knew what we would have at the end is the age of blood as a continuum. And if, in fact, if you look at the histogram on the age of blood that is published in the article, you do see this overlap between the two treatment arms. And what that has allowed us to do is to do an actual exploratory analysis to try and get at that question, whether really fresh blood may be better than the really, really old blood. The other thing that's happening, and I've worked for the past year with the NHLBI folks and the investigators of the ABLE and the recess studies, because we're planning on doing what's called an individual patient meta-analysis. So we spent a year and finally have data sharing agreements in place to be able to share the raw data from each of the studies. So we'll do a meta-analysis using the individual patient data, but more importantly, we're now going to have almost 2,400 patients from the ABLE study and 1,200 or so patients from recess that we'll be able to add to inform data to re-explore those two extremes, the very fresh and the very old blood. So you're not going to see another study done that actually just randomizes people to 1 week old stored blood and the oldest blood. But I think it's very likely that we'll come up with an answer by combining all these studies and doing these exploratory analyses, which will address that question. And hopefully either make people comfortable with 42-day storage, depending on what we find, or it may lead to reducing the storage duration to 35 days or less. We'll have to see what we find.
As long as it's not 8, Nancy, because if it's 8, I'm in big trouble.
Well, I promise you it will not be 8.
Okay. I may hold you to that.
Okay.
So I mean, I think pretty clearly we can say that this is not the end of the story, but it's a substantial step along the way in the story. Is that a fair way to put it?
Yeah. I think people are really reassured. And, I think the blood bank people who might listen to this podcast or, who read the article, they should be reassuring the physicians who practice in their hospitals that, in fact, there isn't really an indication for ordering fresh blood just because, the cells don't look good under the microscope and, you don't want that old stuff being given to your patient. And the fact that, it would have detected, if a difference existed, it would have detected a 1 to a 1.2% difference. And we didn't see that. So I think it's very reassuring.
Okay. Well, and I know, Nancy, that there's more to this story, and we don't have time to go into a really interesting article that you and your colleagues published earlier this year in Lancet Hematology that suggests that maybe some of the things that we're doing to the blood in the background in terms of how we're processing it may have an impact on all this as well. But like I said, I don't think we have a lot of time to go into that. But I do want to close with one more question for you. And this is I may be surprising you with this slightly. I apologize for that in advance. But there is something that I've noticed, and I actually I know that you've noticed it because I saw it on one of your slides. We've kind of gone this whole thing in the background view has been old blood. We're trying. I guess in a way we're trying to disprove that old blood is bad, but okay, fine. But when you look at the studies that have been done, the randomized studies that have been done, not an overwhelming difference, but in most of these studies, there's actually a little bit worse mortality in the fresh blood. I mean, what do you do with that information? Again, I know it's not something that you can go out and say, don't give fresh blood, but how does that strike you, Nancy?
Yeah, one of the things that I think it's important when we do research is to look at our observations and, to kind of say, what's the message, or is there a message there? And I agree with you. I've ever since ABLE came out and when INFORM also had a slightly higher frequency of mortality in patients who received the fresh blood, I thought, man, could fresh blood be harmful? And if so, why would that be? And I think that's just something that I think we should pursue it because there are still people who get fresh blood in certain hospitals. The NICU babies in the neonatal ICU, in many centers, they tend to get fresher blood.
Sure.
Like, are we causing harm? Certainly, I'll make the point that all of the studies to date have been designed as superiority studies to show that, fresh blood is better than old. And just because we're seeing that trend in the opposite direction, we can't make any conclusions that, maybe fresh blood is worse than old. But I think it raises an interesting hypothesis, which, I know our group is certainly interested in pursuing it and digging a bit deeper to see if we can figure out if something is really there. And hopefully others are too.
Right. Well, I guess that might fall into those one of those categories of for all the people that have come to us and said, "Don't give us that bad old blood." It might be be careful what you make us look at, right?
Yeah, exactly.
Obviously, way too early to make any definitive conclusions about that. But Nancy, I can't thank you enough for this discussion. I think it's been really, really. I'm going to say it. I can't help it. Informative.
Oh, that's a bit of a pun, isn't it?
It's not much of one, really. Not much. It's cringeworthy, is what it is. But
I told
is there
you,
anything else?
I told you, Inform was a great name.
It is, clearly. It leads to dummies like me making silly jokes. So, is there anything else you'd like to mention before we close our discussion?
Well, I know we're pretty much out of time. The only thing that I just might go back to and try and address in 1 minute is the pragmatic design.
Yes, thank you for remembering.
And I'm hopefully on your website we'll be able to put up a reference if people want more information about this. I think pragmatic designs, they can't be used to answer every question, but I think they're the way of the future. If for no other reason because of, the incredibly low cost for doing a huge study that you can achieve with a pragmatic design. We're almost putting ourselves out of business when we start doing these big clinical trials where you have, 50, 100, 150 sites. Every site you have to have a REB approval. Every site you have to have like a data sharing and agreement to participate. That in itself sometimes takes up to 3 years to get all of those contracts in place. Wow. And, just to illustrate how electronic data collection can be so helpful. We did the Inform study for $40 US per patient. I don't know the actual cost of Recess and ABLE, but I think they're somewhere in the range of $3,000 plus per patient enrolled.
Wow.
And I think that just illustrates, that we could do a lot more research if some of these questions we could answer with a pragmatic design.
Bet. Well, Nancy, thank you again very, very much for hanging with me and having this really helpful conversation. Folks, just so you'll know, Nancy and I will work together to make sure that we have references on the show page at bbguy.org/podcast. You can find the episode there, and we'll hopefully try and get some slide images on there as well. But a lot of useful information in this discussion. And Nancy, again, thank you so much.
You're very welcome. I'm honored to participate. Just for your viewers and people who go to your website, when you first approached me, I told you that our transfusion medicine fellow trainees love the blood bank guy. They quote your information all the time. So it was really nice for me to meet the blood bank guy.
Well, I am incredibly honored. Thank you so much, Nancy. You have a great day.
Thank you.
Hi, everyone. It's Joe. I just want to thank you for taking the time to listen to this podcast. I hope that you found it informative. I want to make sure that you know that there's a lot of great reference information for you on the Blood Bank Guy website. Just check bbguy.org/podcast. Find Nancy's episode and you'll find slides and links and references and all kinds of good stuff there. So with that, I want to wish you a great day. And as always, to let you know that as you go through your day, I hope that you smile. I hope that you have fun. And above all, never, ever stop learning. Thanks a lot, and we'll catch you next time on the podcast.